Thank you, Dr. Sarah, Simon, dear friends. Thank you to my friends from Cardio, Jean-Jacques Bensoussan, especially Yves Elbez, and all my friends. If I understood well, I have, with the other Ariel this morning, 20 minutes for the two talks, so it won't be possible to give all the information I've prepared. So I will go very quickly to the first and the last part of my talk, and will focus on the middle part of my talk. So the first question was, why do we have to assess asymptomatic patients? And you had answers from the previous talk. So, of course, we need a Doppler echo at rest for these patients to evaluate all these parameters that have been discussed in depth by Maurice. And I won't go into depth into all these parameters, but keep in mind that in asymptomatic patients, reduced functional capacity is related to the prognosis. So it's interesting to have this information. What does it mean that the patient is really asymptomatic? In fact, he is not when you perform an exercise test. As you see, there is a relation between the functional capacity and the prognosis. Now, in this study from Raphael Roseneck in Vienna, it has been shown that among 132 patients, surgery was performed in 38 patients, and it included patients with symptoms and also those who had left ventricular involvement or dysfunction or pulmonary hypertension. And if you just look at this watchful waiting strategy in asymptomatic patients, there was no significant difference in the prognosis. But if you look into detail in this study, you see that patients who were operated were those who had symptoms. Mainly, 2/3 of the patients who had surgery developed a symptom during this watchful waiting strategy. So if you decide not to operate asymptomatic patients, you have to look after this patient very carefully. And Maurice has shown this slide previously. We need to look at the volume of the mitral regurgitation to be sure that nothing happened, because there is a clear relationship between the effective regurgitant orifice and the occurrence of events in asymptomatic patients. So why do we have to perform stress echo? And of course, if I had to ask the question to the people in this room, who is performing exercise and stress echo, I think that not many people do it, because it's not that easy to perform this stress test. Of course, we have the experience with evaluating ischemic patients with coronary artery disease, but it's not that easy to perform. At the same time, the echo study and the Doppler study, both with continuous wave Doppler and also with all the modalities that you can use with Doppler. So usually you have a stepwise increase of the heart rate with an increasing loading during the exercise, and at each step you have to recall the images and also to perform echo to measure the PISA and also LV filling pressures if you have some time to, and also mainly pulmonary artery pressures. So you have to evaluate all these 4 parameters during exercise and also at post-exercise steps to make sure that something is happening or not happening with the patient. So you have this kind of example. This is from at rest and at peak rest. You have to look precisely to the PISA and especially to the regurgitant orifice and to measure it, not, of course, during the exercise test, but offline to compare all these values. And by doing that, we have some studies regarding organic mitral regurg. If I have a few minutes at the end of my talk, I will give also some information regarding mitral stenosis. So we have 3 main bodies of evidence regarding this question. And the first 2 studies, this one from Lung and the following one, deals with post-exercise echo, and they have measured the volumes and also ejection fraction during exercise, post-exercise, not during exercise, I'm sorry. And by using these kind of values, they shown that it was possible with a good accuracy to detect early post-op LV dysfunction. So it's possible by performing stress echo and especially exercise echo to have parameters that can be implemented in the instrumentorium to evaluate feasibility of surgery in this patient. And the second interesting study deals also with post-exercise, and this study included 71 patients, asymptomatic mainly, and the question was, is it possible to detect the presence of contractile reserve, yes or no? And you see that there is a clear relationship between the presence of contractile reserve and the possibility of having a normal LV function after surgery. In other words, you see that the main predictor of a normal post-op LV ejection fraction was the presence of pre-op contractile reserve. These two evidence show that it was possible to measure these parameters during post-exercise. And also, it has been clearly shown that there was a prognostic consequence of that those patients who had contractile reserve by stress echo do not have any event at follow-up. So it's very interesting to have both parameters, not only LV ejection fraction, but also contractile reserve and also measurement of the effective orifice area. Now we have the third body of evidence, and it is exercise measurement of all these parameters by the Liège group headed by Luc Pierre and Patricio Lancelotti. And they have shown very convincingly that by evaluating 61 asymptomatic patients with mitral regurg, it was possible to measure LV volumes and ejection fraction and to show that during exercise there was a significantly increase of all these parameters. And by looking also of the quantitative evaluation of mitral regurgitation, it was obvious that there was an increase in both the volume and the regurgitant orifice area, and also the volumes of the left atrium, and also of the pulmonary pressure. So we have all these parameters that have been measured during the exercise test that are really helpful because, you know, it helps to stratify patients with a change above or below this value of regurgitant volume 15 milliliter. It's possible to show that there is a clear difference between these two groups of patients. It's possible to really risk stratify this asymptomatic patient by using exercise echo. And also a very interesting observation by this group was that there is a correlation between the evolution of the regurgitant orifice during exercise and pulmonary pressures at exercise. And you see that one of the main predictors of exercise pulmonary hypertension is the regurgitant orifice. So there is a clear relationship between these two parameters, and you see that it's also possible to have a distinction between those who had or who didn't have pulmonary hypertension at rest, but especially during exercise, the presence of exercise pulmonary hypertension was correlated to a bad prognosis in this patient. So it's very interesting to try to collect all these parameters during a stress echo. And finally, also in this study from this group, it has been shown that the best predictor of the occurrence of symptoms in these asymptomatic patients was the occurrence of pulmonary hypertension during exercise with an hazard ratio above 3. So again, it's really very, very interesting to collect all these parameters during an exercise test. So my final question regarding mitral regurg is it possible to detect those patients who have a normal LV ejection fraction by looking at the 2D speckle tracking and especially measuring myocardial thickening and shortening below the presence of LV ejection fraction and LV dysfunction? And it has been shown again by this group, Patricio Lancelotti mainly, that it was possible during exercise to show the decrease or increase of the strain in patients with normal left ventricular ejection fraction. And also they have shown that it was a good predictor of postoperative LV ejection fraction. Don't look at all these lines, but just at this one during exercise. in patients with normal LV ejection fraction, abnormal longitudinal global strain was correlated to the prediction of postoperative LV dysfunction. So perhaps it would be very interesting to have also this approach in patients with normal LV ejection fraction. So
Dr. Cohen, I'm going to have to ask you to conclude, please.
I know, because I just had to talk after the surgeon, but usually when we speak before the surgeon, we have more time. So I will give you my conclusion. My friend Gilles Dreyfus took 30 minutes for his talk, and I had only 15 minutes for exercise. So I had to exercise myself. So my conclusion, perhaps it's the best way perhaps to conclude. I have one slide with the guidelines, and I have tried to draw an algorithm regarding what I have prepared. So the guidelines are those that you know, and you know that exercise is implemented only with regard to pulmonary artery pressure, and it's a class 2A in the ACC guideline, and that's all. It's not a priority to perform exercise echo. And also in mitral stenosis, I didn't have time to show you some of the results we had, especially from the Bichat group, but also it's a very poor indication of exercise. I think it's because of the fact that we do not have enough experience in our departments. So this is my conclusion. Of course, these are not guidelines, but this is the way we're working in my department. And we are trying. Of course, in symptomatic patients, it's quite obvious, and Gilles Dreyfus is here to operate this patient very quickly. But in those who are not symptomatic, of course, we perform as our team here in this room transthoracic TE echo, and we perform in all patient stress tests, and we look at three components. We look at the occurrence of symptoms, at the oxygen consumption, and also at all these parameters that have been recorded during exercise tests, and we implement these observation and results in the way we are deciding to operate this patient. Thank you very much for your attention.